cerebral aneurysm and aneurysmal subarachnoid hemorrhage, another silent killer. Author Mabel Cruz for Rasmussen College. This PowerPoint is being submitted on March 1st, 2015 for Michael Molesky's G150 Structure and Function of the Human Body course. Cerebral aneurysms are defined as a weakened or thin portion of the vessel in the brain, which fills with blood. They are classified in two ways, by type and size of diameter. There are three different types: saccular, which is a pouch-like sac attached by a stem or neck to a blood vessel; lateral, which is a bulge on the side of the vessel wall; or fusiform, which is just a widening along the vessel wall. As far as size of diameter, we look at small being less than 11 millimeters, large 11 to 25 millimeters, and giant bigger than 25 millimeters. Aneurysmal subarachnoid hemorrhage is defined as the rupture of a cerebral aneurysm which results in an emergency condition with high fatality rate. And this picture here shows how a ruptured aneurysm allows the flow of blood to flow out of the vessel and therefore is not able to continue its normal circulation in the brain. When we talk about etiology, we have to consider pathophysiology and risk factors. As far as pathophysiology goes, it is still somewhat unclear, but links do exist between the relation of the location of the aneurysms and arteries that they are found in. Links also exist to the amount of endothelial progenitor cells in the peripheral blood of aneurysm patients. Risk factors can be non-modifiable or modifiable. Non-modifiable includes genetics, gender, and ethnicity. Modifiable includes smoking, birth control, and alcohol consumption. So let's talk a little more about pathophysiology. The flow of blood in the brain begins at the arch of the aorta through the subclavian and common carotid artery and finally reaches the brain through the internal and vertebral carotid arteries. And in the vascular system of the brain, aneurysms usually occur at the bifurcation points and large arteries that branch off from the circle of Willis, therefore breaking the circle of Willis. The circle of Willis is formed from the posterior communicating arteries and anterior communicating artery joining circulation, and therefore they create this circular structure that allows for cerebral blood supply to continue even if one of those contributing arteries becomes narrowed or occluded. At a deeper level of pathophysiology, aneurysms have been found to be related to the amount of endothelial progenitor cells, EPCs. EPCs are rare cells that circulate in the blood and differentiate into mature endothelial cells, which make up the lining of the blood vessel. These cells therefore maintain normal function in vascular endothelium as well as help repair it. But in people with cerebral aneurysms, the number and function of the endothelial progenitor cells have been found to be severely decreased and therefore cannot maintain proper function of these vessels. Risk factors include genetics, gender, and ethnicity. So we have a family, a boy and a girl, and a globe. As it relates to genetics, risk factors, we have to consider connective tissue disorders and hypertension because they relate to the pressure effects on the arterial wall and therefore allowing for aneurysm formation. We also have to consider familial occurrence of intracranial aneurysms and heritable connective tissue disorders. Several studies have found that between 7 and 20% of patients with aneurysmal subarachnoid hemorrhage have a first or second degree relative with proven intracranial aneurysm. When we talk about gender as far as risk factors, when we have little boys who tend to be more prone because in childhood to adolescence, boys or male gender is more prominent for subarachnoid hemorrhage. But somehow by age 60, more than 50% of aneurysmal subarachnoid hemorrhages are found in women versus men. As far as ethnicity is concerned, 4 studies have shown that based on population, African American and Hispanic descent were more likely to experience subarachnoid hemorrhage in comparison to Caucasian descent. So even though we cannot control the previous factors, we can control factors such as smoking cigarettes, contraceptive use, and alcohol consumption. Impact on other systems or other body systems is that the development of multi-organ system dysfunction was associated with a greater likelihood of unfavorable neurologic outcome, and SIRS, which is Systemic Inflammatory Response Syndrome, with secondary organ system dysfunction, was the primary non-neurologic cause, resulting in death of people with cerebral aneurysm, which resulted in aneurysmal subarachnoid hemorrhage. And the severity of both central nervous system dysfunction and extracerebral organ system dysfunction correlated with a degree of neurological impairment. Also, with increased neurological impairment is the increase of a chance to develop SIRS, in which case 77% of extracerebral organ system failures happened in conjunction with SIRS. So it's very important to mention 51% were respiratory, 97% were renal, 100% were hepatic, 96% cardiovascular, and 73% hematopoietic organ system failures that occurred with SIRS. Signs and symptoms. Most aneurysms go undetected because most patients are asymptomatic until the aneurysm is either very large and difficult or not able to be treated or ruptures. Signs and symptoms also depend on the severity of the bleed and the site of the rupture. Signs and symptoms prior rupture. We noticed that 15 to 39% of people with subarachnoid hemorrhage have a leak or minor hemorrhage from the aneurysm, which produces warning headaches called sentinel headaches. Other symptoms that people may experience prior rupture is pain above and behind the eye, dilated pupils, inability to move one eye in certain directions, or vision change. And all this is just prior to rupture. However, it is very closely related to some symptoms, signs and symptoms post-rupture. Once rupture occurs, the most common initial symptom is a sudden onset of severe headache, often described as the worst headache of my life, and these are called sentinel headaches. The warning headaches are the sentinel headaches. The worst headache of my life is the after rupture of the aneurysm. Additionally to the headaches, some people also experience drooping eyelid, double vision, symptoms of meningeal irritation such as sensitivity to light, nausea, vomiting, and stiff neck, as well as focal neurological deficit such as weakness in the limbs and facial paralysis that they can experience with cranial nerve palsy. Also, seizures, change in level of awareness, and loss of consciousness may all be present. Diagnosis. When we talk about diagnosis, we have to talk about the misdiagnosis and how common this is because of the symptom of headache being the main common symptom. Symptoms tend to be attributed to things such as migraine headaches, hypertensive encephalopathy, and systemic illness. So for proper diagnosis to occur, the first line of diagnostic treatment is CAT scans because they have a 95% sensitivity in cases that are detected within 24 hours and 75% in cases within 72 hours after rupture occurs. Now, if these CAT scans come back as negative. A lumbar puncture should be done 12 hours after hemorrhage in search for xanthochromia. Xanthochromia is a yellowing in the cerebrospinal fluid, and it is found in all patients with subarachnoid hemorrhage. As far as treatment goes, there is cerebral angiography, which is used to visualize the aneurysm and its location to help decide further treatment. Furthermore, once they do that, then we can decide to do either surgical clipping or endovascular coiling. And there are two options in the treatment to occlude the aneurysm, and these are it. So if they decide to do surgical microvascular clipping, then this will be performed under general anesthesia. A section of the skull is removed and the aneurysm is located. A microclip is placed around the neck of the aneurysm so that blood can no longer enter the aneurysm and prevents further bleeding. Also, endovascular embolization coiling, if they choose to do this, it is less invasive, but it is also performed under anesthesia. A catheter is placed into an artery, usually the femoral artery, and threaded via angiography-aided visualization to the aneurysm site. The coil is then detached from the catheter with an electrical charge, and this charge causes thrombus formation into the aneurysm, fills the aneurysm, and therefore blocks further circulation, causing the aneurysm to be destroyed. As far as short-term consequences go, short-term consequences for aneurysm and aneurysmal subarachnoid hemorrhage are direct complications or results from treatment. People must remain in bed until the bleeding stops. Usually this is 6 months minimum. Other symptoms or consequences is seizures, vasospasms, and hydrocephalus. Seizures need to be managed with anticonvulsants and analgesics for headaches. Vasospasms require calcium channel blocking medications and sedatives for restlessness. Shunt placement into a ventricle may be necessary if hydrocephalus develops. And if rebleed occurs secondary to vasospasm or hydrocephalus, death is the most probable outcome. So it is imminent that these consequences need to be controlled. Long-term consequences. Per Connolly and RCP, which are part of my resources, we find that roughly 50% of people who survive aneurysmal subarachnoid hemorrhage are left with some type of deficit, either it be physical or cognitive. And survivors will need rehabilitation services such as speech and occupational therapy to regain function and help cope with the disability. Even if they make a good recovery, deficits with attention, concentration, and memory may still be experienced, and it is estimated that only 1/3 of survivors do return to their previous occupation prior to aneurysmal subarachnoid hemorrhage. In conclusion, aneurysm and aneurysmal subarachnoid hemorrhage is a life-threatening condition, and it can be fatal or, at very minimum, leave people without the life that they were previously enjoying. And they have to learn how to adapt and just to accomplish the activities of daily living is going to be quite a task for them. Management of this condition is difficult, and so both the public and healthcare professionals should be properly educated and aware not only of the symptoms but of the best possible treatments and how to guide the patient so that they can decide on the best possible care. In this way, they can accomplish together the best possible outcome. Aneurysms that result in subarachnoid hemorrhage are a silent killer this way. It is up to us to be on top of our health care, and with this information, hopefully it will be easier to keep on the lookout. Finally, here are my references. If you have any questions, please feel free to go back and review.